Hello everyone, today we are going to deeply understand antiadrenergic drugs, not just as a classification, but as a clinical decision making tool. We will move step by step from alpha blockers to beta blockers and understand why each drug is used, not just where. Let's begin with alpha 1 selective blockers, starting with the most important drug, prazosin. Prazosin selectively blocks alpha 1 receptors on vascular smooth muscle, leading to vasodilation. Now, what makes prazosin clinically important is not just vasodilation, but the type of vasodilation. It causes both arterial and venous dilation, which reduces both afterload and preload. Because of this, it reduces blood pressure effectively without significantly increasing heart rate. Why is reflex tachycardia minimal? Because alpha 2 receptors are still intact and they continue to inhibit norepinephrine release. Now coming to uses. Prazosin is used in hypertension, benign prostatic hyperplasia, also sometimes in PTSD related nightmares. In BPH, it relaxes smooth muscle in the prostate and bladder neck by blocking alpha 1 receptors, improving urinary flow. Now the most important adverse effect, postural hypotension. This is especially prominent after the first dose, called the first dose phenomenon. Mechanism: sudden vasodilation causes venous pooling, leading to decreased venous return, thereby decreased cerebral perfusion and syncope. This is why the first dose is always given at bedtime. Other adverse effects are dizziness, nasal congestion, mild reflex tachycardia. Now compare this with non-selective alpha blockers like phenoxybenzamine and phentolamine. These block both alpha 1 and alpha 2 receptors. Now this is where the problem comes. By blocking alpha 2 receptors, you remove the negative feedback on norepinephrine release. So norepinephrine levels increase, stimulating beta 1 receptors in the heart, leading to marked tachycardia. So these drugs cause severe reflex tachycardia, arrhythmias, more hypotension. What are the uses? They are mainly used in pheochromocytoma, where there is excessive catecholamine secretion. Phenoxybenzamine is irreversible and long-acting, making it useful for preoperative control. Phentolamine is short-acting, used in emergencies. Now let's move to beta blockers, starting with the prototype, propranolol. Propranolol blocks both beta 1 and beta 2 receptors. Let's understand its full clinical impact. Beta 1 blockade, decreased heart rate, contractility, cardiac output. Beta 2 blockade causes bronchoconstriction, vasoconstriction in peripheral vessels, inhibition of glycogenolysis. Now, uses of propranolol are wide. These are hypertension, angina, myocardial infarction, reduces mortality, arrhythmias, migraine, prophylaxis, essential tremor, hyperthyroidism, reduces sympathetic symptoms. Now, Distardent is very important because of beta 2 blockade, causes bronchospasm, therefore contraindicated in asthma. Can worsen peripheral vascular disease, masks hypoglycemia symptoms in diabetics, causes fatigue and exercise intolerance. So propranolol is powerful but non-selective and risky in certain populations. Now let's move to selective beta 1 blockers such as atenolol, metoprolol, bisoprolol and nebivolol. These drugs primarily block beta 1 receptors in the heart. Advantages over propranolol: minimal bronchoconstriction, thus safer in asthma, less effect on peripheral circulation, better tolerated in diabetics. Now uses are hypertension, chronic stable angina, post-myocardial infarction, heart failure, especially metoprolol and bisoprolol. Nebivolol has an additional advantage. It causes nitric oxide mediated vasodilation, improving endothelial function. So remember, selective beta blockers are cardioselective and safer. Now let's move to drugs with intrinsic sympathomimetic activity, ISA, like pindolol and esputalol. These are partial agonists. So instead of completely blocking beta receptors, they partially stimulate them. Advantages: less bradycardia, less reduction in cardiac output, less disturbance of lipid metabolism. So when do we use them? In patients who cannot tolerate strong beta blockade, like those with baseline bradycardia, peripheral vascular disease. But important point, they are not preferred in myocardial infarction because full blockade is required to reduce mortality. Now let's move to drugs with additional alpha blocking activity such as labetalol and carvedilol. These drugs block beta receptors leading to decreased heart activity and alpha 1 receptors leading to vasodilation. So they reduce both cardiac output, peripheral resistance. Now clinical uses are: labetalol is used in hypertensive emergencies, pregnancy induced hypertension, very important, and carvedilol in heart failure. Hypertension. Why is carvedilol useful in heart failure? Because it reduces afterload and also prevents harmful sympathetic overactivation. Now let's conclude with high yield integration. Alpha 1 blockers like prazosin, good for hypertension and BPH, but cause postural hypertension. Non-selective alpha blockers cause tachycardia and are used in pheochromocytoma. Propranolol is powerful but causes bronchospasm. Selective beta 1 blockers, safer, cardioselective, widely used ISA drugs. cause less bradycardia, not useful in MI, alpha plus beta blockers, best for hypertension and heart failure. Final clinical takeaway, always choose antiadrenergic drugs based on receptor selectivity, patient comorbidities, desired hemodynamic effect. If you understand this logic, you don't need to memorize, you can predict drug actions clinically. Thank you.